Ladies and gentlemen, what I'm going to do is not so much focus on the advantages of the new detector as such, but focus on a couple of indications that were already possible before the new detector, but now, because of the new detector, are able to be done with a substantially lower amount of radiation. Now, let's start with a few things, simple things like single-shot imaging. Single-shot imaging is something that we're using, for example, for pediatric. Here you see the comparative sizes of a normal chest and a pediatric chest. And because of the boost of low contrast performance, you basically easily create images with a resolution that is very similar to what we get in an adult, but for extremely low dose and in a single rotation. The important part here is that actually you're doing that with an in-room switch, which basically is very similar to what we're used to do in chest x-rays in children, where you basically look for a moment where the child is quiet and then press the button and you get a shot. Takes about 0.275 on the newest scanner. So it is something that is very, very reliable when it comes to the image quality of pediatric CT. The other thing that's actually where dose doesn't really play a role is single-shot trauma imaging for wrist trauma. What you basically do is you stand behind the scanner, put your wrist into the scanner, no scanogram, and you just pull the trigger and get a scan. So no scout radiograph, fixed MAS, and it's something that is really very helpful in detecting occult fractures. That's, for example, one of our radiographers who tripped over an ultrasound cable. She had a radial head fracture that was seen on a conventional X-ray, and the scan actually revealed that there was an additional fracture of the humerus. Now, it's a common problem, as you know. Most of the scaphoid fractures, or not most, but 40% of scaphoid fractures can be missed initially, and by doing a CT instead of X-rays, you are basically picking those up. Does it really always affect treatment? We don't really know, but especially in a scaphoid, it is very likely that that's happening. Now, perfusion imaging is one of the areas where dose is an issue, and the classical ways of doing that vary between shuttle modes, where you have detectors that are not able to cover the whole area, so you have to go to and fro, or toppling table techniques for detectors that can cover half the range, or basically you can do volume scans, which would be done with the Aquilian systems, where you can do that at different intervals, or you can do a continuous scan, which can be done if you want to look at very fast inflow-outflow situations like in AV malformations or fistula. Now, the advantage of the volume scans are obvious. They allow the identical time tags, which is different in a shuttle mode or in the toggling table technique, high sampling rates, and extreme flexibility. One of the things that we're playing around is what we call a one-step stroke imaging protocol, in which we basically substitute one of the brain CT scans by a neck CTA and then jump back to the brain. By doing so, we are able to kind of get the cervical CTA within the same contrast injection and have still a reliable scan of the head. We tested it in phantom studies, removing certain scans from the diagnostic CTP exam, and found that it's actually the error is below 3% in these patients. Now, how does it look like? Here's an example where you can see the neck scan plus the scan of the brain. It means 50 milliliters of contrast, or if you use the techniques that we just heard, even less are sufficient. Now, one of the new things that's coming up is that we're working on new reconstruction filters that actually use the total information of the 4D dataset to reconstruct high-quality imaging. And what that actually opens up is to skip also the pre-contrast CT scan. So basically being able to reconstruct a non-contrast CT from the noisy dataset from the CT perfusion and still getting very good image quality. Here you see a very reasonable white-gray matter differentiation on the filtered thin sections that actually came from the original data set that you see up there. Now, why would we not use a pre-contrast CT anymore? Because in very many of these stroke indications, we now have an indication for doing some contrast injection. For the hemorrhagic strokes, we'd like to see a spot sign which shows that it's an active bleeding. And for, of course, a normal stroke, we'd like to see the amount of perfusion defect plus also the vascular structures. So that again saves time and radiation dose, as well as contrast dose. Other things that we can do with these detectors is do abdominal CT, and the fun thing is that we can interleave it with a normal CT scan. So basically we do perfusion, high-dose hepatic arterial phase, more perfusion scans, portal venous phase, and then a few late-phase CTP scans. By doing so, we take advantage of the full amount of contrast, which gives an extremely high signal and therefore extremely high-quality images when it comes to CT perfusion. Here's an example of a pancreatic head carcinoma where we do see in the blood volume image dropout and a moderately reduced perfusion in this blood flow image. Another example where we see another tumor here with a very low perfusion in the area of a pancreatic head. Why is that important? Because we can use that to detect isodense tumors, but also help differentiate various tumor type. And it seems also that it has a predictive value because higher blood volume predicts lower grade tumors, which basically have a better prognosis. And we also can use it for pancreatitis, where perfusion predicts vasospasm and potential complications. Now, a whole new area where you do multiple scans is dynamic imaging, and again, reduction of dose is a critical issue here. Here is an example from Monash Medical Center in Australia, where they looked at patients with treatment-resistant asthma. And it turned out that many of those patients actually didn't have asthma, but instead a vocal cord dysfunction, in which the vocal cord kind of collapses during breathing and creates exactly the same symptoms as asthma. And obviously, the treatment is very difficult. Inhalants won't work, so you really need to have functional treatment by a logopedist or perilaryngeal Botox injections to kind of relax the muscles around there. We've already seen that image. That's a situation where we can see the sliding of a tumor along the aorta, which basically shows that there's no invasive invasion of the pleura and therefore also obviously no invasion of the aorta. If it sticks to it, it doesn't really mean that it is a transpleural invasion. It just means that we can't really differentiate if there's mediastinal invasion or not. But it's a very high negative predictive value for this particular question. A completely different area where you kind of move into an area that we haven't been able to do, it's a dynamic swallowing. It's here an example from Professor Kadada from Fujita Health in Japan, where you have a special table and the patient basically swallows during the scan, and it allows for a complex analysis of the swallowing situation, especially with patients with dysphagia. That is something that he found very interesting and very helpful, and finding also the right treatment options in these patients. Dynamic motion analysis is an area where it comes to skeletal applications. The big issue there is that it can be really difficult to evaluate. The main reason is if you try to move your wrist, you're not only moving the wrist itself, but you're also moving the radius and the ulna. So by kind of fixing it in a digital fashion, it is much easier to visually analyze it, but also to measure these data. And by doing that, you get curves that can allow you to kind of also quantify that and see the effect of treatment on your patients. Another application is dynamic imaging. Here, for example, in aneurysms of the head, the idea being that if you have an aneurysm that pulsates more, it has probably a thinner wall. We know that from if you try to blow up an air balloon, it usually takes a lot of pressure, and at one point the wall becomes so thin that this becomes very, very easy, and it's very similar here in aneurysms. What you can see here is there's a little blip here that occurs during the cycle, and that's actually an area that is at higher risk for rupture, so an unstable wall in that particular region. Stroke, we've seen that. The most important question there is detecting, of course, the occlusion, but also whether there's collateral perfusion. Collateral perfusion is a very strong predictor of outcome of stroke, or actually if there's a lack of collaterals, it's a strong predictor of a negative outcome. You can also use it for AVMs, identification of feeders, dynamic filling of the nidus, or planning of interventions. Study from our place where we basically showed that a so-called timing invariant CTA, which is basically condensing all the CTA information from the CT data set into one image so that you can see the arterial collaterals in one image without having to go through the 4D data set, is actually extremely good at predicting a poor outcome. In other words, what happens is if the collateral status is poor on these images, then there was no single patient in which we found a good outcome after treatment. Another area is treatment planning of IVMs. I'm going to try that. Okay. What you can see here, the classic situation is that you have a certain frame rate here, 2 frames per second, which actually in these fast-filling structures is not fast enough to be able to really find the feeding vessels there. By kind of creating overlapping data sets, you can create 10 frames per second. And in these situations, it's continuous scanning that we're doing during a very short period of time. Again, a detector that allows that for lower dose is absolutely welcome here. Finally, subtraction imaging. Subtraction imaging is, I think, a very good and interesting alternative to dual energy when it comes to the detection of iodine. I'll show you why. The idea is you have, of course, multiple breath-hold acquisitions, and you basically match them. Above, you can see the original data, and below, you see the data after matching. And by doing so, you can see basically the subtracted areas. You can even subtract arterial and portal phases. And the interesting thing is that if you do iodine perfusion maps from subtraction, then the signal-to-noise ratio is substantially better than dual energy, because you're not really subtracting signal from the high kV data, but you're subtracting 0, namely the baseline, which gives you a much higher signal in these patients. That's what I'm showing here. If you have a 100 kbp scan and a 140 kbp scan, like is usually done for dual energy in the abdomen, the signal that you see is just this little blue thing in dual energy. When you basically do subtraction imaging, you take the full signal, so signal-to-noise ratios for these techniques is much superior than dual energy. Dual energy has other advantages, for example, for renal stones or for removing contrast from the bowel in virtual colonography, but when it comes to dynamic injections of IV contrast, this is a much superior technique. We've seen some of the examples of subtraction imaging already, and the interesting thing is there you can see not only the emboli in the pulmonary arteries on your CTA, but you see what happens to the lung in this patient. And you can see that this large embolus on the right side has almost completely eliminated the perfusion of the right upper lobe. And on the left side, we see a couple of really large perfusion defects and a few areas in which the perfusion is relatively reduced because of an obstruction, but not a complete one of the lungs. Subtraction imaging can be used in other areas, for example, here in the bones. It's an example from Ellen Bloom from Nancy, who basically shows in this patient with a bone lesion that there is a highly enhancing structure there, and that's actually quite typical for fibrous dysplasia. Subtraction can also be used for CTA, that's very clear. Here we see a patient in whom we have a stent in the carotid, and on a subtraction image, it's easy to see that the left carotid, where the stent is placed, is actually occluded. But it's good collateral perfusion because the left hemisphere is still perfused. Now, when it comes to cardiac imaging, there are lots of things that we can do, and all of those actually profit from low-dose imaging, especially, of course, the perfusion and the dynamic images. Now, what I'm going to show is a few other things that have come on top of that. One is an advanced motion compensation software, which actually adds just a bit more to the compensation of motion in cardiac imaging, basically by tracking the coronaries and basically using this tracking in the post-processing or actually the filter back projection to make sure that the image quality becomes better and actually these blurred appearances become much more rounded and much more sharp. The area of calcium in the coronaries is always a problem. We know that calcium makes it very difficult for us to evaluate the coronaries, and calcium subtraction is one way of dealing with it. The only problem is that if you want to really do some registration, it can be very tricky. So the technique here is that you do a rough registration of CTA and the calcium score with the pre-contrast image, and then you register only the calcified plaque very, very nicely, and then subtract that calcified plaque from the original image, and then that is what you get. Here's a patient with an occluded stent from Dr. Chen from the NIH, or from Dr. Kofut. An example where just the opposite is the case. On the subtracted image, we see it's actually a normal coronary, despite the fact that on the unsubtracted image, it's one big mess of calcium here. So basically, the summary of the recent developments that you can do with the Y detector and with the new detector elements is that the one-shot imaging in trauma and pediatric becomes now something that can be done extremely quickly and with a very low dose. Dynamic CT and CT angiography are something that are entering the realm of routine imaging. Same holds true for advanced perfusion, although the things that I've shown you are still works in progress. Interleaf body perfusion is something that we already can do now. Subtraction imaging is available as a product, and comprehensive cardiac assessment is a reality. Thank you for your attention.
Thank you very much. We are exactly in time, so we have time for one question to Dr. Prokop. So with these new CT techniques, it seems like we are taking over from conventional radiology in some of these applications. And I'm wondering when that will happen to some extent. So Dr. Boole was also referring that the chest film may be done by CT in the future. So can you speculate for which indications the new CT technology may take over from chest film radiography for certain indications or certain patient groups, where this CT will offer the most advantage in this respect?
We've seen that already happening for the renal stones, for the CT urography, where basically the normal IVUs are basically gone. We're basically seeing that for the colonic exams, where basically a normal colon exam is almost gone in most institutions. The question, when it comes to the chest X-ray, we've discussed that just right before. We have one point. The chest X-ray is something that's very cheap, and it's also cheap because we're very rapid at evaluating it. So if we really want to go that way, then we need help from some software that allows us to really read these images really, really rapidly and fast so that we can stay cost efficient. But the technology as such is no longer the limiting factor. What's the limiting factor is us and the reimbursement we can get for it.
And for which clinical indications it will be most attractive? I think myself, for example, for pulmonary infection, there's so much issues there, also in the clinical arena. To diagnose a pneumonia is not so easy, and there is a lot of uncertainty. So would that be a good indication to test this technique?
I think for all bronchial and lung parenchymal disease, it is superior to chest X-ray. We have no idea how good we will be when it comes to a cardiac congestion. Probably we were better, but we have to look at different areas there. There's one area where we cannot do it, which is the ICU lungs. But for most of the others, we'll probably see it go away. And what you could even speculate is that if the technique's so good and our CAT systems become even better, that we will not read normal scans anymore. So a CAT system will look at it, it looks normal, we don't see it.
Okay, we will see how the future will be.